So, our next speaker is Dr. Michael Seidman. Michael Seidman is a board certified psychiatrist and fellow trainee in behavioral neurology and neuropsychiatry at the University of Colorado School of Medicine. He cares for patients with Parkinson's disease and other neurodegenerative conditions in the behavioral and cognitive neurology section of UCH and has an interest in neuropsychiatric symptoms that can come with the context of other neurologic conditions. He is interested in emerging treatments such as transcranial magnetic stimulation with a broadening range of indications in neurologic populations such as Parkinson's disease. So please join me in welcoming Dr. Michael Seidman.
Thank you, Phyllis. Thanks for that introduction. So nicely written. Just it's great to be here. Thanks for welcoming me. Thanks also, Lisa, for that awesome presentation on just like mental health support in general. So it's a real privilege to be here. Is this the little clicker? Does it have a laser pointer too? Oh, cool, perfect. Try not to mess it up. So just to introduce myself a little bit further, I am Mike Seidman. I am a physician at UC Health and University of Colorado. And I'm a psychiatrist by training, as Phyllis mentioned. So I went through general training in psychiatry, and I've gone on to work at the university as a fellow, which means in fellowship, it's like extra optional training that doctors can undergo to become even more specialized in a specific area. So from the very beginning, my big interest was in the brain and how does our brain, whether we have a diagnosis or just like a member of the general population, how does this thing between our ears generate all the weird things that we experience as consciousness, perception? And a lot of people that go into psychiatry and neurology are kind of curious about that. So I really wanted to learn more as a psychiatrist from the neurological perspective and learn more about how different conditions like Parkinson's disease can affect the ways that our brains think and function and perceive the world and exist in reality. I do work with patients with Parkinson's disease, and I really am proud and excited to be part of the Parkinson's Association because from the beginning of my training, it was very clear to me that Parkinson's is almost the prototypical or like the ideal neuropsychiatric condition because it affects so many systems of the brain that have a direct connection to our personalities, our behaviors, and how we perceive things. It's not just a movement disorder, but it's a whole brain condition. So I love working with Parkinson's patients, and I'm always excited to meet people in the community. Um, Give this clicks. Where do I aim at? Oh, down. Oh, okay. Got it. So I always like to start with kind of a review of terminology too, because it can be very confusing with all the alphabet soup of terms and conditions that get thrown around as diagnoses. But really, it's a lot simpler than all of these terms make it seem like, because all of the conditions, whether you've been told you have Parkinson's disease or Lewy body disease or dementia with Lewy bodies, it's all caused by one kind of medical process at a molecular level. And that's like some of this up here. They're all caused by this misfolded protein called alpha-synuclein. And we all have alpha-synuclein in our bodies. It serves normal roles, but in these conditions, cells start to produce a misfolded version of it that likes to clump up and form clumps and aggregates. And when they clump up together enough, they can actually be seen on a microscope. And some German doctor named Dr. Lewy was the first person to look at slides from the brains of people with Parkinson's disease and notice these abnormal clumps. And so they're called Lewy bodies. And that's why all of these conditions together are called Lewy body diseases. I think in the future, someday we'll probably call all of these like Lewy body spectrum disorder or alpha-synuclein spectrum. But right now we have all these terms like because of basically the way they were discovered. So when people have more like physical symptoms first, tremor, slowness, freezing, imbalance, they get diagnosed with Parkinson's disease. That was the first condition that they defined. Later, they realized that there are some people that had more cognitive challenges from the very beginning, and that was their main symptom. So that got a different name. It's called Lewy body dementia. And if the cognitive symptoms came at the very beginning as like one of the first symptoms, it's called DLB, dementia with Lewy bodies. So very confusing. Lewy body dementia, not the same as dementia with Lewy bodies. Because people with Parkinson's disease, where they had physical symptoms first, they can go on to develop very strong cognitive symptoms. And then that's called Parkinson's disease dementia. Because both of these conditions end up with dementia, they're called Lewy body dementia. So all of that is to say, don't stress about all of these terms. It's pretty much one disease, and depending on where it's active in the brain, it's just labeled differently. Parkinson's disease is basically a condition that involves the loss of dopamine. So what happens in Parkinson's disease, this is probably like very review to a lot of people, but just to remember, Parkinson's disease starts in this deep structure in the brain. These deep structures are called the basal ganglia, and there's a specific part of the basal ganglia called a substantia nigra, which is really the brain's dopamine factory. In Parkinson's disease, the dopamine producing cells in the substantia nigra start to die off. And that is really the supply chain for the whole brain's supply of dopamine. So in Parkinson's disease, there's less dopamine production, and that leads to, in different pathways, all of the different problems that we see in PD, essentially. So dopamine has to be in balance for us to function well. And problems with dopamine being too high or too low can lead to things not feeling comfortable or not running smoothly. How many people have ever experienced having too much dopamine in their system? Like either taking too much levodopa? And can anyone just call out if you're comfortable, like what did that feel like? I'm just curious, but I'll talk about some of the ways that it can feel. But basically, it's important to remember that Parkinson's disease makes our dopamine levels too low, and so we try to treat it by giving the brain more dopamine through medications or other treatments, pumps, etc. But having too much dopamine and having the balance out of whack in different circuits can cause problems too. So this is how it can manifest in some of those circuits. So this is in the middle is the substantia nigra where most of the dopamine is produced. But then from there, it has all of these supply chains. So it projects out through pathways to all kinds of different parts of the brain, especially to form circuits or loops of neurons communicating with each other between the deep structures of the brain and the frontal lobe, which is all of these areas up here. So different pathways that dopamine projects to regulate different aspects of our experience and our behavior. So the classic Parkinson's disease physical motor symptoms mainly comes from this pathway, the blue one, the nigrostriatal pathway. That is involved in making our movements smooth, planning motor things that we want to do. But it also projects to these other systems. There's the mesolimbic system, which helps us regulate emotions and factor in information that's important to us to tell ourselves how we should feel in a given situation. And also the mesocortical pathway, which regulates thinking, learning, and processing information. So dopamine really applies directly to all of these different domains. And that's why Parkinson's disease is a multi-domain condition. And this just illustrates those circuits a little bit better. All of these black lines are literally neurons that extend and connect to each other to communicate, and they form loops, just like a circuit in a computer. So they're constantly sending information around back and forth, getting inputs and outputs from different structures, and that helps us regulate all of these systems, emotional, physical, and cognitive, to help all of those things stay in balance and function smoothly. Not too much, not too little, just like a thermostat. So different circuits can be out of balance either by having too much dopamine or too little, and they could be it can also counterintuitively be that there's too much dopamine in one system at one moment, at the same time there's too little in another. So Parkinson's disease symptoms can look really, really different in different people depending on that balance of volumes in these different circuits. So for example, in the motor system, too little dopamine leads to the classic symptoms, physical symptoms of Parkinson's disease. This means not moving enough, having stiffness, tremor, imbalance, walking problems. But too much dopamine in that system can lead to extra movements, which was a common reason that when people get on a good dose of levodopa, they sometimes develop extra movements as an effect of the medication. It's hard to get that system exactly in balance. Same thing applies to these other circuits, emotional, too little dopamine. Dopamine's kind of like a stimulating neurotransmitter. So when we don't have enough of it, we can feel depressed, we can lose our motivation, feel apathy. It can also cause anxiety. But too much can cause too elevated of a mood, like you can feel euphoria. You could have difficulty regulating impulses, just kind of like go and do things impulsively. And in the cognitive domain, too little dopamine it really results in slower processing speed. Memory is there, information, you can still be smart with information, but it takes a little longer for the gears to turn. And if there's too much in that system, it can lead to ideas coming too quickly, so much that they stop making sense or you can't string them together. It can also lead to bursts of creativity, or if there's really a lot, it can even lead to hallucinations. We'll talk a little bit about each of these. The other really important thing, and something that I think connects directly to Lisa Page's talk, is that you're a whole person before and during Parkinson's disease. So everything that you've gone through in life, all of your experiences, the upbringing you had, the relationship you had with your parents, your relationships now, your intrinsic personality, if you've had trauma in your life, your brain has already learned how to function and serve you as a whole individual person. And so all of those systems already have an established way of functioning. And then this little troublemaker, Parkinson's disease, gets into that system and makes tiny adjustments and changes these levels of tone in these different systems up and down. And that can cause Parkinson's disease, even though it's one condition, to look really different in different people, because it's throwing your systems out of balance in a way that's totally unique to you. And it's always a combination of who you are and what the disease is doing. So when Lisa asks, like in a common situation, if you're working together as, like a care with your caregiver, and the person's asking, like, is this the Parkinson's disease, or is this you, or is it the medication? The reality is most of the time it's all of the above. And it can be really hard to know exactly what's what, but the important thing is continuing to work together. And so for the next part, I'm going to talk about some of the common mental health issues that do come up in Parkinson's disease, with the understanding that it's a little bit different in each of us. Okay, depression is one of the most common conditions in the general population and affects up to a third of Americans, and affects more people in Parkinson's disease. So in Parkinson's disease, between 35 to 50% of people with the diagnosis will experience depression at some point. In mental health, we can label depression by different terms, also depending on its features, just like we do with synuclein conditions. So we might call something subsyndromal depression if a person's kind of feeling blue, feeling down, but they don't meet the full criteria for depression. It doesn't reach that threshold yet. If someone feels depressed all the time, sometimes people say, I've felt depressed since I was a teenager and it's never gone away. I never get released from it. In psychiatry, we call that persistent depressive disorder, or it used to be called dysthymia. Because of the dopamine changes in the brain, the condition Parkinson's disease might cause depression directly, because you're otherwise not a depressed person, but you don't have enough dopamine now and you feel depressed. So that's called depressive disorder due to a medical condition, or in this case, due to Parkinson's disease, we would say. You might also just have a recent diagnosis, a new life-changing diagnosis, and a doctor telling you have Parkinson's disease. It changes the way you view yourself, and that can be called an adjustment disorder, where an immediate stressor is causing you to feel differently. So that can result in a depressive condition. And then finally, major depressive disorder or major depression is a defined criteria where if you have enough symptoms of depression, you meet the criteria, which I'll show you on the next screen. It's important to recognize that major depression or depressive conditions aren't just feeling sad. They have all of these other symptoms, and some of them are felt in your body. Some of them show up in different unexpected ways. So this is how we as psychiatrists actually diagnose depression. You have to have at least 5 out of these 7 criteria to be in major depression. One of them is sleep. It can be sleeping more or less than normal for you. A big one is not having as much pleasure from things that you would normally enjoy, like something you've always enjoyed, a hobby or something that's meaningful to you. It just doesn't seem to give you any enjoyment anymore. That's called anhedonia, but it means lack of pleasure. Feelings of guilt can be common. It can feel like something specific, just like more sensitive to feeling guilty for things, but it can also be general, just like I have a vague sense of guilt, or I feel like this disease is a punishment, or things like that. It can come up in a variety of ways. Feeling a loss of energy, feeling tired or fatigued. And as you can tell, some of these things overlap with just the symptoms of Parkinson's disease. It can be very hard to tease apart. Diminished concentration, also something that overlaps a lot with Parkinson's disease itself, and dopamine changes. Changes in appetite, which can be having your appetite be much more than usual for you, or more commonly much less than you normally want to eat. Can also overlap with Parkinson's disease if you've had changes in your sense of smell. That can affect your enjoyment of food. Psychomotor agitation or retardation, that means moving faster or slower than is normal. And obviously, again, it's something that's very clouded in Parkinson's disease, where slowed movements is a core feature of the condition. And then thoughts about suicide, thoughts about death, or even this exists on a spectrum where sometimes that comes up as, I don't want to end my life. I'm not going to do anything actively, but I wouldn't mind if I didn't wake up tomorrow. It's on a spectrum, and it's much more common and not talked about enough than you might think. Anxiety is also very common and often comes about with depression, hand in hand. It can affect up to 40% of people with Parkinson's disease. We categorize it just like depression in different ways, depending on how the symptoms look. The majority of the time, it's a generalized anxiety, where the person worries more about just anything and everything, whatever's on their plate at that moment, just an easier threshold to get worried about it or not be able to stop or control that worrying. But if it's more specific to a specific area, like I don't feel anxious most of the time, but if I have to go to an event like this and be around other people, I feel really anxious. That could be called social anxiety. Or a really distressing form of anxiety can be panic attacks, where anxiety for usually short periods of time, like 20 or 30 minutes, but it really goes through the roof, and it feels like it can feel like you're convinced you're going to die because it's so bad, and your heart is racing, you're sweating, and then usually it goes away on its own after 20 or 30 minutes. That can be called panic attacks as an extreme form of anxiety. Um, in Parkinson's disease, anxiety is most often seen when the Parkinson's disease flare up. That can be during off periods or when medications wear off. And it's a natural, understandable response because all of a sudden you've been moving smoothly, you can control your body, and then it feels stuck. And that would make any of us anxious rationally. Um, just like depression, anxiety is not just the feeling anxious or feeling worried. It can come up in kind of unexpected ways that I want to highlight a few of. It can commonly manifest in your body, like feeling more muscle tension, muscle aching, heaviness. Obviously, another thing that overlaps with Parkinson's disease, but if you notice those feelings more, especially when you're worried and anxious, it might be a manifestation of anxiety itself. It can result in a restless feeling, like an inability to sit still, need to move around, get up, pacing. And it, just like depression, it can affect sleep. Classically, in anxiety, it tends, or one of the most common ways that it affects sleep is waking up too early. Say you went to bed at midnight and you want to wake up at 8 o'clock, but you're up at 4 or 5 in the morning and you're feeling anxious. You're just kind of like in your thoughts, ruminating, worrying about things. That's a very common way that we see anxiety affect sleep. And it can also not just feel anxious, but irritability can be a manifestation of anxiety too. So if you're just kind of quicker to get frustrated, um, that can be one of the common ways that anxiety actually shows up. In the clinics, most of you have probably seen forms like this, and a lot of primary care doctors have integrated mental health screenings into their practices. So these are two screening forms that you might see. They're called PHQ-9, which is for Patient Health Questionnaire 9. It just actually enumerates the symptoms of depression and asks you to rate how often you've been dealing with it over the last 2 weeks. So this is a really quick way that we can kind of screen for depression. And as you look through this, if you're recognizing some of these things in yourself and they're happening more days than not, it could be a good sign to like kind of bring it up with your doctors. Same idea for this questionnaire called the GAD-7, which screens for anxiety symptoms. Okay. Apathy is a favorite topic of mine because I've studied it and I do research on apathy. So when I was in medical training, I particularly noticed that my patients with Parkinson's disease and also other neurological conditions like strokes or Alzheimer's disease, some of them had this curious phenomenon where they lost their motivation. They just felt less drive to do things. Their care partners would say, I really need to kind of like push my husband or wife now to do things to bring them to these appointments. And it caused a lot of frustration for caregivers, not so much necessarily for the patient themselves. But what was curious to me is that this doesn't always overlap with depression. Obviously, when you're depressed, your drive to do things is reduced, but a subset of patients I saw had less motivation and less activity overall, but it didn't really bother them. They weren't depressed. And in neuropsychiatry today, we call that apathy. It's defined by reduced goal directed behaviors. It's very common in Parkinson's disease, again, because of reduced dopamine in some of those circuits, reduces our brain's ability to look at inputs from the outside world and decide what's important, what's relevant, what's pertinent to my goals. That system's just underactivated overall. Um, and so it's one of the almost hallmark neuropsychiatric symptoms of Parkinson's disease. I want to share something else about that. Um, yeah, what differentiates it from depression is generally the negative affect, negative mood is more seen in depression, sadness, low mood, feeling guilty. That can overlap with apathy, but it can also just, the person can just be less concerned, seem blunted, do less on their own in apathy. Okay, in Parkinson's disease talks about mental health, it's always important to talk about psychosis as well, because it can be a stigmatized condition, but it shouldn't be, and it's very, very common in Parkinson's disease. Um, Minor changes in perception are extremely common in PD. Up to 40% of people with PD have minor perceptual changes. So that can be just illusions like misperceiving something, seeing a movement in the peripheral vision and then turning and looking at it and nothing's there. Or looking at patterns like in a crazy carpet pattern like this and seeing like faces or things, and usually the person has good awareness and insight that that's not real. It doesn't really bother them. More um, more significant hallucinations are less common. They affect about 10% of people with Parkinson's disease. um, Hallucinations are defined as changes in perception, so actual sense data from any of your five senses: hearing, vision, smell, or touch. But in Parkinson's disease, it's almost always visual. So people will, if it goes beyond seeing things passing through your visual field or shadows moving, it can start to be like well formed images, like seeing a person standing there, seeing a small animal. Even when that happens, the person usually has pretty good insight and can tell that it's not real, or they ask their care partner, oh, yeah, I think that's just a Parkinson's hallucination. And it's weird, but it doesn't really bother them. Um, so, because of that, and also because of our understanding that hallucinations are directly caused by too much dopamine, the drugs that we can prescribe for hallucinations and psychosis are generally pretty bad for Parkinson's. So we try to avoid them unless we really, really need them. So the first line of defense is reassurance. If the experiences that a person is going through do not bother them, they have good insight, they're not doing anything unsafe, reassurance is the first line of defense. And sometimes it bothers care partners even more than it bothers people with the disease or the experience. So sometimes it's about caregiver education, saying this is not dangerous, it's not going to hurt them, they're not doing anything unsafe. It's okay to just work with them through it. Reassure them, you're there with them, you love them, it's okay. But if it's distressing to the person or it's interfering with day-to-day function, the next step is to try to reduce dopamine medications if possible, if they can tolerate it in terms of their physical symptom control, because too much dopamine is usually the culprit. If you remember that earlier slide I had of all the circuits and having too much dopamine in these systems, it's really hard to balance this seesaw, because imagine you had like a plate of food and you've made a delicious dinner with steak and green beans and mashed potatoes, and the steak and green beans taste good, but the mashed potatoes taste dull. So you decide you want to add some salt. Well, with dopamine medications, the way we have to add the missing ingredient is by climbing up a 10-foot ladder and trying to sprinkle salt on your plate from way above. So you might make your potatoes taste good, but maybe now your steak tastes too salty. And that's usually what happens with these symptoms of extra dopamine. We've added a medication to try to help the person move better, but oh no, now you're having some abnormal experiences, some hallucinations or other neuropsychiatric symptoms. So if you can lower the medications and that's tolerable, that can usually help with the hallucinations. As a last resort and only as like kind of a last line of defense, we use antipsychotics. The reason it's like reserved for the last line of defense is because these medications work by blocking dopamine, which obviously can make Parkinson's disease worse. There are many antipsychotics to choose from and that doctors prescribe, but a few of them are safer or less dangerous in Parkinson's disease. Those are the ones here. We don't have to go into the details, but it's just important for your doctors to know that you have PD, or if you're ever in an ER, that the doctors treating you know that you have a Parkinson's diagnosis, because they have to choose these medications carefully. Just on the topic of changes in perception, to highlight that some of these things are normal. We, as humans, there's a part of our brain that looks for faces because we're social animals. So we see faces everywhere we look. But in Parkinson's disease, this phenomenon is enhanced. You see even more faces than normal. And it's kind of just an interesting thing that scientists and neuropsychologists have discovered about people with Parkinson's disease. This phenomenon, which is normal of seeing faces in things, is called pareidolia. And because of that observation, some really smart neuropsychologists developed a test that can actually differentiate people with Parkinson's disease, where there are these ink blots, and you show people these ink blots, and you say, how many faces do you see? So how many faces do you all see in this picture here? Does anyone see one by show of hands? Does anyone see more than one? Does anyone see more than two? Okay. How about in this one? Does anyone see one? Nobody sees a face there. Well, that's good. This one doesn't have any faces in it. But in large studies of Parkinson's disease, people with the diagnosis are more likely to count more faces than are actually in the picture. In this one, this is the only full face, but our brains are just like pattern recognition machines, and you can imagine, even with or without PD, you could imagine seeing faces or drawing a picture based on these. These are some drawings by a patient with Parkinson's disease who was a professional artist who also experienced psychosis. So he had the experience of people coming and visiting during the evenings, and so he would stay up until dusk and wait for these visitors to arrive, and then would immediately paint his hallucinations to capture them. So this one on the left was called Geisha. This one was called Mick Jagger. This one was called Are They Coming? Are They Going? And this one was called Friends. So just an illustration of how these experiences are common and usually not distressing. It can be interesting. Impulse control disorders are also common in Parkinson's disease. This is almost the opposite of apathy, where apathy, you lose your drive to do anything. In impulse control disorders, it's ramped up and it's too much. So your drive is to do everything or do things quickly without pumping the brakes or having other parts of your brain say, hold on, this might not be the time to do that. It's common, up to 60% of people with PD, and it actually comes from too much dopamine in these circuits. And just like psychosis, it can be an effect of accidentally adding too much gas to the other systems that we aren't targeting with these dopamine treatments. So it's especially common when people start dopamine therapy, like you're trying levodopa for the first time. Some of the ways that it can manifest are just things that, if you imagine as a human being, you might have a momentary impulse to do, but then you say, that might be risky, or my wife might not like that. So things like gambling too much, excessive spending, going on shopping sprees, sexual behaviors are very common, like not being able to control the sex drive. But eating too much, kind of high reward foods. It can also lead to creativity, kind of just like increased productivity of everything. It's more common in younger patients, more common in male patients, and more common in people that have a history of certain psychiatric conditions like alcohol use, depression, or anxiety. It's also, just like psychosis, it's not always problematic. This is another illustration from a Parkinson's patient who was a photographer and had been photographing flowers, and the way that they photograph flowers changed as they developed impulse control disorder. So they got closer and closer to the flowers. This patient would spend hours dissecting flowers, examining the inner structures, and felt a strong drive and impulse to catalog and typify and organize everything. So it would create these intricate color spectrums of all the flowers arranged by colors. it became a part of his art practice. Cognitive changes are common in Parkinson's disease too. Changes in thinking can affect up to about a third of people with Parkinson's disease, and it becomes more and more common as the disease progresses. So if someone that's had the disease for 3 or 5 years has a lower risk of having any impact on their thinking than someone that's had the disease for 15 or 20 years. Um, the most common way that Parkinson's affects thinking, it's easy to remember because it's the same way it affects movements, it's slowing. So usually in PD, unlike in Alzheimer's or other memory disorders, the person has pretty good memory still, and their mental faculties are actually generally intact, but it can take longer for the gears to turn. You ask a question, it might take a little longer for the answer to come, but usually the answer is right and well reasoned, just as it would have been before this condition. So it's important, especially for caregivers, to hear that someone's slowing of thinking doesn't mean that they can't think, and to just allow extra time. Parkinson's can also impact executive functioning because of lack of dopamine. Executive function is our brain's ability to regulate over all the other strengths that it has. So it's important for planning, multitasking, organizing. If you have a big goal, you have to do step 1, then step 2, step 3, and then go recheck on step 1. That's executive function. Memory and reasoning are usually preserved, just slowed down, as I said. It can also impact visuospatial dysfunction. This can have an impact on judging distance, judging navigation in 3D space, driving, and those systems rely on dopamine as well. So now we know how to recognize some of these common domains that are impacted in Parkinson's disease. What do we do about it? That's the important thing. So in mood symptoms, depression treatment and anxiety treatment, the good news is that general mental health treatments work really well. Also something that, like Lisa highlighted, that the approach in therapy doesn't necessarily change, and it turns out that these are experiences that we all go through as humans to one degree or another. And the good thing is that since they're so common, we've developed over time pretty effective ways to help with them. So some of the interventions, like Lisa provides, like therapy, some of the common types of therapy like CBT, cognitive behavioral therapy, supportive therapy, other types of therapy can be just as helpful whether you have Parkinson's disease or you're a human living life or both. Medications, something that I specialize in as a psychiatrist is medication management. And so the general medications for mood conditions like depression don't really change too much in Parkinson's disease. They don't make the disease worse. There's none that we have to choose selectively because a person has PD. So the first lines of defense are things like SSRIs, like Zoloft, Prozac, Lexapro, meds like that. And a good primary care doctor or a psychiatrist is usually very comfortable working with these. Both medications and therapy, studies show they work better together than either one alone. There's some synergy between them. And then, as was mentioned at the beginning, one of my personal interests as a neuropsychiatrist and straddling this divide between neural circuits and mental health symptoms is newer treatments that are emerging that let us directly target brain networks without taking a medication that goes throughout the whole body. That's very exciting to me. So one of the areas that I work in is called TMS, transcranial magnetic stimulation. This is an illustration of how it works. It's a non-invasive treatment where a machine that generates a magnetic pulse is put near your head on the scalp. And by generating magnetic fields, it can cause neurons in the brain to fire completely non-invasively. Very safe, generally very little discomfort. And it's been FDA approved now for a number of years for depression, but it's being studied more and more in neurological conditions and Parkinson's disease in particular. Right now, the access is limited because insurance generally covers it for severe depression where a person has tried medications. But if you have PD and you also have depression and you're in that category, there's a lot of research accumulating that shows it can be helpful in PD specifically, both with other non-motor symptoms and physical symptoms even. For very severe mental health symptoms like depression with suicidal thoughts, or the person's not eating so much that they're losing a lot of weight, they're going to end up in the hospital, ECT is safe, and it's used in Parkinson's disease patients, and it's been shown that it's safe and effective. This is a medical procedure where a person is put under anesthesia and they intentionally create a brief controlled seizure. And that actually helps tremendously in people with severe depression or even psychosis or behavioral issues. Um, has a mixed PR reputation because of media, One Flew Over the Cuckoo's Nest, et cetera. But it's one of the oldest, well-established treatments in psychiatry, and it's actually extremely safe. It's been FDA approved in geriatric populations, pregnant people. Um, yeah, happy to talk more about that. But something we think of if things are so unstable that we don't have time because it works really well and it works quickly. Okay, and what about dance? This was new for me. But over the last 5 or 6 years, there's actually been a lot of research into dance as a mental health and well-being intervention in Parkinson's disease. This is results from a meta-analysis where they pooled a bunch of studies together, and they showed that dance has actually like a lot of benefits in Parkinson's. And it kind of makes sense when you think about it because it's getting you to move your body, similar to like the rock steady boxing. So you're improving strength, mobility, balance. It helps on that level. And then at the same time, you're getting into the community, doing something fun, connecting with other people. You might be dancing with your partner. So it has all of these well-being and mental health benefits as well. Okay. And then lastly, I'll leave some time for questions at the end. Thank you. Um, Preventing things before they become problematic is really helpful as well. So if you're doing well, the things that you can do to strengthen and bolster your support system so that you can weather different stresses that might come up are like strengthening your support system, building that connection and intimacy with your care partner, connecting with your family, being involved in communities, being involved in friendships is really important and really protects us, builds resilience to prevent things from getting worse. If you have pre-existing mental health conditions that you already know about, like, hey, long before I had Parkinson's, I did struggle with depression, PTSD, or bipolar disorder. Doing all you can to make the care of that optimal is also helpful. And taking medications exactly as prescribed. This more is a problem, especially like for younger patients or people that are new to dopamine medications, but um, you don't have to raise your hand, but if you've ever taken too much dopamine or taken more dopamine in one go, that can lead to problems like we talked about of having too much dopamine. So just following instructions, communicating closely with your doctors is really important. Knowing the common issues, which we just went through, knowing what to look for, and early warning signs to bring up to your team. And lastly, it's really helpful to just know yourself, know who you are, know what matters to you in life. When I work with people in therapy, I spend a lot of time clarifying, like, who are you? What matters to you in life? What do you want people to remember about you? Because it turns out most of the time, even if you have a condition like Parkinson's disease, or you're dealing with something else really hard, or your ability levels have changed, your strengths and weaknesses has changed, there's still almost all of the time a way to connect with the things that matter to you in life if you can clarify what those are. Um, so this is a list of all like kind of personal values that you might have. Checking on the time, I think we have time for this. Something I wanted to do with you all. Do I have until the hour, by the way? Okay. Okay, cool. So we'll have plenty of time for Q&A. So everyone, okay, 10 minutes, cool. So if you have a pad of paper and a pen near you, I'd like everyone, whether you're care partner or Parkinson's person or something else, take a few minutes to try to find 5 words on this list that connect to you as your own personal values and write down your top 5 personal values. These can be the things that you feel like at the end of the day, these are the things that make life worth living. Or at the end of my life, if I'm gone and passed away, these are the things I want people to look back on me on and say, hey, this person really lived by these principles. So I'll give you 3 or 4 minutes to write down your values. They don't have to be from this list if you have your own ideas. There's blank spaces like there, so you can come up with your own. If it's too small, maybe just think about your own answers, what your own answers would be to that question. And if anyone feels comfortable just calling out what something that's important to you is that you wrote down, feel free to just shout it out. Fun, patience, service, compassion, kindness, competence, faith, gratitude, empathy, trustworthiness. Yeah, there are as many different answers as there are people in this room. And that's what's really interesting and special to me is that my answers might have zero overlap with someone else, but they're all kind of like what makes us unique and what gives us humanity. As you make this list, if you've done it side by side with your if a care partner's here today and you've both done it, it can be interesting to compare your lists and see where you overlap, where you don't overlap, how that might come up for you as a partnership. In a condition like Parkinson's disease, things change. That's the only rule that we know. Like things change over time, and how you connect or are able to connect with those key important things might be different. And that can be demoralizing. So, one of the most common drivers of kind of mental health struggles is, say, I value competence. That was one of the examples. And um, I can't take online classes at Harvard anymore. You know, I can't keep up with the same pace, or I can't do the habits that I can't participate in fun activities like I used to go kite surfing or skiing every year, and I can't do that anymore. But if you put your heads together, either on your own or in reflection with a care partner or with a professional like a counselor, there's almost always creative ways that you can find to connect with those important things in a new way at any ability level. And I think that's one of those universal pillars of mental health and counseling work and things for me. So I'm glad we had time to kind of go through that. And um, I have some time now for questions and answers. This is just a summary slide of some of the broad categories we talked about. But if anyone has questions, I'd be happy to talk more about anything or talk afterwards.
Just, yeah, if you have any questions, again, just raise your hand. I'll bring you the microphone. And we've got a few more minutes, so let's have some questions. No questions? Here we go. We got one.
Is there any correlation with this and bipolar disorder? A lot of these signs and symptoms seem like that, especially on that first slide.
Which symptoms were reminding you of that? Mhm. Yeah, yeah. So bipolar is like a mood disorder as well. Let's go back to that real quick. Yeah, this one. Whoops. This. Yeah, yeah. Euphoric mood, impulse regulation. Those come up in bipolar disorder too, and it does involve some of these same circuits and regulation. Bipolar disorder is usually not caused by Parkinson's disease, though, because it results in that system being activated for episodes that can last days or weeks, and then it goes away. And it kind of does its own thing where it swings between too much activation, too little. And it also causes other symptoms because of just it's a different disease pathway. It overlaps with this, but it can also cause the person to have so much energy that they don't need to sleep. We don't usually see that in Parkinson's, even with dopamine medications. So there's definitely overlap, and that probably, although we don't fully understand exactly what happens even in bipolar disorder, it stands to reason that there's likely some shared circuitry here, which is why the symptoms can overlap and look the same. Great question.
You raised your hand again. I misplaced you. I saw a hand in the back of the room. Oh, okay. Here we go.
Dr. Seidman, is it fair to ask you to comment a little bit on the status of research into Parkinson's and the cure?
We're waiting for that.
Yeah, I wish I could answer that question about what's the cure for Parkinson's disease. A lot of really smart people are working on it. We know a lot of the possible targets because the protein, whoops, where is that? That picture. The protein pathway is known really, really well, but we're still doing work to understand why this protein misfolds. Some of the research that I'm the most excited about are the symptomatic treatments. So can't say that they're cures, but those neural circuit-based treatments like transcranial magnetic stimulation are really exciting to me because right now, as you might know, we mainly point that stimulation treatment at this center of the brain that's involved in depression, and it helps really well for that. But that magnetic coil, we can turn it around and put it at any different structures in the brain. So there are a lot of studies that have suggested that by stimulating some of the motor areas with TMS, you can treat Parkinson's disease, tremor, slowness, imbalance, help with physical therapy interventions. It can enhance some of the other treatments. And that's not yet FDA approved, but it's something I'm really excited about because I think it will come to mainstream treatment in the years to come. And this is a very generalizable premise with fewer side effects because we're not kind of having that salt from on top of the ladder effect. We can put the stimulation exactly where we want it and not have collateral damage and other effects on other systems that we're not trying to target.
Okay.
I'll stick around.
Yeah, great. Thank you. Thank you so much, Dr. Seidman. That was wonderful.